minutes, so just please hold all your questions to the end. So, we've been talking a lot in recent weeks, I think last conference in particular, about OBS units and our expanded role as ED doctors in running these units. And so this lecture is going to focus on an issue or frustration we're definitely going to encounter on these units. So these things usually start off with a case. So guy walks into the ER, and the details are probably going to be important later for technical reasons, but let's just call him Heart 4 to 6. Or whatever Gestalt scoring system one uses to risk stratify your chest pain patient for MI, so that they're not low risk enough that they can leave, but you're not activating the cath lab right away. So his first stroke is negative, you can get him to OBS. So we rule out our MI with troponins, or whatever fashion your institution rules out MIs. It's going to be at least a 12-hour. There's some evidence for 16 or 18 hours. But at the end of it, this guy has stable vitals. He has not made any troponins. We've been doing successive EKGs, and there are no changes. He's chest pain free. So, I missed a slide. Now what? So I've been asking around at our institution and other institutions. So at this point, the decision is usually made by cardiology. In some cases, they're going to stress the guy. In some cases, they'll cath. And sometimes, after 3 negative troponins or 2, 12 hours apart, they're just going to wave goodbye and send him on his merry way. And there doesn't necessarily always seem to be a great logic behind it. But we know that there are actual recommendations. So we end up stressing these guys. Why do we do it? Because the AHA says so. The main question is, where does this recommendation come from? Why are we doing it? Skipping slides. Okay. This is the AHA recommendation. We've all heard of this in one form or another. That any patient who's admitted for low-risk chest pain should be getting a next day or 72-hour, some form of provocative testing, which we call a stress test. So we're doing it because the AHA said so, but I think it's important to understand what we're looking for, because there's some confusion. We're not looking for acute MI. A lot of this confusion has to do with the language, the way we mix up ACS and MI and which type of MI. This is a 2010 statement from the AHA that the primary indication for confirmatory testing is to minimize the likelihood of ACS so that you're safe for discharge. I want you to notice there's no citation over here. There's no paper that they quote that actually proves this. So let's review just sort of the pathophys a little bit. The ACS that we care about is the stuff that we can do something about. There's the picture above, some type of blockage in the coronaries that's going to get categorized as an NSTEMI or a STEMI and by positive biomarkers. And then we're going to go through some type of intervention with PCI, with thrombolytics, or we'll anticoagulate and give antiplatelet agents. The scary question is, what if there's a chest pain that's thought to be ischemic that we're not seeing with our biomarkers within our rule-out time, right? So we call this entity unstable angina, and it has a very specific pathophysiological process, but I'd like you guys to just think about it in this way of biomarker negative ischemic chest pain. So does this biomarker negative ischemic chest pain have a mortality effect? Do people die because of it? And some of the early trials in MI, like the GRACE trials, showed that these people potentially did worse. So maybe we need to be finding this. So do we? Is stress test helping us with that? And I'm obviously baiting a little bit because Michael Scott says no. There are a bunch of studies evaluating what these stress tests do, and the consistency throughout is that enzymes identify all the MIs, and stress tests do not identify any additional patients that have a short-term risk that are missed by enzymes. An important point here is that when we're calling something in MI, a lot of these definitions have to do with how sensitive biomarkers are. The original studies about unstable angina were done when we were still calling things Q-wave MIs. We were using CKMB. In the age of highly sensitive and certainly ultra-sensitive troponins, there are a lot of people that argue that maybe unstable angina is gone as an entity. There isn't myocyte necrosis that we're missing with negative enzymes. There's a great paper called Unstable Angina, Time for a Requiem that Dr. Zatopchi has recommended a couple of times And those unstable engines are probably recategorized now as NSTEMIs. So when we stress test after our negative troponins, what we're really trying to do is see if there's a significant supply-demand mismatch to cause the symptoms or ischemic changes on whatever testing modality we're using. I.e., we're looking for CAD, narrow pipes. So the problem is that even when we come outright and study whether these tests find coronary artery disease, it's a bad test. I mean, look at the range on these sensitivities. When you calculate the likelihood ratios for these, the positive is between 2 and 5, and the negative is hovering around like 0.2. I mean, and 0.5. Like, these really only change your risk if you have trouble with likelihood ratios by about 15 to 30%, depending on your prevalence. It's just not a good test, and according to the AHA, they're really only indicated for people with intermediate risk by whatever scoring system you want. If you want to go old school, you can use Framingham. That's what it's indicated for. People who are low risk, it's not going to bump them to high risk. And people who are high risk, it's not going to bump them to low risk. So it's really only useful in these intermediate risk patients. So I'm not saying we don't need to find and treat coronary artery disease. We know that coronary artery disease has some form of effect on mortality, but there's debate among studies how much it is. And there's stuff that we can do that helps. If anyone says we don't need to find CAD because the treatment's all the same, there are mortality benefits for revascularization in certain forms of CAD. Certainly triple vessel disease in a diabetic, CABG has a mortality benefit. If you go on up to date, they're going to say main LAD disease and two vessel disease with significant stenosis and symptoms has mortality benefit from CABG. So we need to find these people, but do we need to do it in the ER? And on top of that, this is from the JAMA Rational Clinical Exam. I know you guys can't see this table or are going to look at any of the statistics, but this is basically when someone comes into our ER with chest pain, in terms of their history, what are the things that are going to increase or decrease their chances of having an MI? So abnormal prior stress or prior history of coronary artery disease are on here, and really don't change your statistic that much. If you have previous history of CAD, the likelihood ratio is only 2. It doesn't increase your probability of having an MI that much. And conversely, no history of previous prior stress is a likelihood ratio of 0.9. That's barely a 15% reduction if you've had a negative stress test in the past. So there's a great article on EMICM about what do you do with that patient who's had a negative stress test 3 months ago and they come in with chest pain. Does that lower their risk of MI? And the answer is no, it doesn't. So why are we working so hard to stress test these people? Let's go back to the original studies from this recommendation. I'm not going to quote all of them to you, but if you go through all of these footnotes over here, none of these studies were evaluating next day stress versus no next day stress. They were evaluating, the first two are pretty famous studies that evaluated the safety and the cheapness of OBS units, that patients didn't do any worse than people who were admitted, and that it saved the hospital money. The rest of them are all just that of people they stress tested, people with negative stress tests did better than people with positive stress tests in terms of things like interventions, which seems sort of intuitively obvious. I don't know why you would need a paper to prove it. So I'd like you guys to think about what type of study would you want to do to evaluate whether a next day stress is actually going to be useful for some type of prognostication. This comes close. Its big flaw is that it's retrospective. They just did it by chart review. But they basically took a ton of insured patients. They did chart review for people who came in, they were low risk for MI, they had at least 2 negative troponins, and they looked at who got stress tested and who didn't, and outcomes. So the bolded words are important. There's no difference at 7 and 190 days of people who had MI or people who were later on admitted to the hospital. No difference between people who got stress tests according to the AHA recommendations and people who didn't. However, the people that did get stress tested got cathed a lot more. They had a lot more complications from invasive procedures. They got caused a lot more harm downstream, which I think is probably more of an internal medicine issue, but we all know that when we open up, testing begets more testing. and it doesn't really look like it makes that much of a difference. There are other studies that also show that the stress tests don't really catch anything, and they don't really seem to help. So, because it's 10 minutes, you can do my takeaway points now. When we do stress tests after negative troponins, we're mainly looking for coronary artery disease. And the important thing to remember, I think, as practitioners, is we're always worried about that missed MI. So, people who have 2 negative troponins in the ER, the most recent study in 2015 shows their risk of having an MI that we're not seeing is less than 0.2%. So, I guess be a little bit, I'm not saying don't be scared, but it's somewhat reassuring when that patient has negative troponins consistently. Stress tests are a useful test potentially in intermediate risk CAD only. That's your question if you haven't, that's the answer to the question if you haven't taken step 3 yet. And lastly, we probably don't need to be finding these people in the ER. We're still going to because the AHA recommends it, but at some point, hopefully, someone in this room will be on the board of ASAP and they can maybe change our policy as EM physicians. These are my references. There are a lot more. I couldn't fit on one slide. I want to thank the whole core content team, Dr. Regan, Lee, Reza, and then specifically Dr. D'Souza, Dr. Friedman, and Dr. Singer for going over all the data. All right, now questions.
In the patient populations from the study that you're referring to, how does that compare to the patient population of Kings County? Is it, like poor follow-up? Because a lot of these people were followed at 790 days. A lot of our patients get lost to the system. Any outcome that?
So the first big difference in that FOI study is that they're all privately insured patients. So I will agree that we're probably dealing with a different population. The study size was, I think, somewhere close to 10,000. It wasn't a small study. Now, that being said, this is the argument that I've gotten from a lot of cardiologists, that people are here, they're in the hospital anyway, they have some type of test that they're going to need to do, why don't we do it while they're here? Really, I think the answer is that they can bill a lot more for it when it's done as an in-hospital test as opposed to an outpatient test. So I don't know how that all figures in. Poor follow-up, I need to see a study that shows that patients do worse because of that follow-up issue before I invested millions of dollars that are getting invested in these prolonged admissions and closing OBS units on weekends because we can't get stress tests. Anyone else?
Are we, our very good lecture is very appropriate. Are we, in our OBS unit that we're doing, in which we have 2 negative components, and we have 6 patients that cardiologist sees the next morning and decides whether they need stress testing, is anybody keeping track of the outcomes for these patients if we're changing management for the patients that are getting the stress test?
So I don't have ops shifts yet. I've been asking people who do that. They're telling me that some people do get stressed, some people don't. Of the people who get stressed, some people get admitted for diagnostic cath, some people don't. It seems fairly varied. I don't know if anyone else on OBS has a different experience they want to share, but that's what I've been hearing so far.
It seems to correlate pretty well to what we think. Like, I can kind of tell you an OBS patient if they're going to get a stress or not based on basically my split. Like, because sometimes we'll admit we OBS people. Like, we OBS a guy yesterday with shoulder pain because he had like some T-wave emergence and we've never seen his other EKG. Cardiology said, actually I discharged him, but I'm pretty sure that cardiology would have also said he's kind of shoulder pain, he doesn't need to have a stress test. So I think that we generally have a good understanding of who is really going to get that. I haven't followed up afterwards to see, who had the abnormal stress and who got that.
So I've also noticed when I did cardiology also tends to do things out of convenience. For instance, there's a holiday that people didn't expect. People had 3 patients who were supposed to get stress tests. They're like, oh, stress lab closed. We'll just do it outpatient instead. So that's kind of, it's not a proper medical decision. It's not guideline based. It's all just whether they have the staff available.
Right, but ultimately they're the ones that are taking the risk, so I guess they get the.
But we're the ones discharging that.
Yeah.
So